it's great pleasure, somebody I've worked closely with over the years, Professor Paul Stallard, who is a professor of child and family mental health at the University of Bath in the UK.
Thank you very much, Panos, for inviting me, and it's a real pleasure to be part of this very interesting symposium. And what I'm going to do in this presentation is I'm going to take a particular focus, and I'm going to be looking at the use of cognitive behavior therapy as a psychological intervention for the treatment of depression in adolescents in particular. Why cognitive behavior therapy? Well, you've already heard it mentioned in some of the earlier presentations that there is considerable evidence base now for cognitive behavior therapy in treating depression in young people. It's over 20 years that the first randomized controlled trial evaluating cognitive behavior therapy was published. And since that time, the evidence base for CBT from randomized trials has grown considerably. So if we look here, when Compton did his review in 2004, there were 12 randomized trials which had 768 participants. But if we now come up to some of the, more recent trials, you'll see that this has grown considerably, and the number of children who've taken part in those trials has also grown significantly. So that we're now arriving at a database with information from many more trials, with many more young people. And I think that it would be very fair to say at this point of time that of all the psychological therapies, cognitive behavior therapy is the best evaluated in terms of research trials looking at its impact upon depression. Well, if you put all these results together, you find that overall there is some very encouraging findings. So if you look at some of the meta-reviews and systematic reviews that have been published, then you find that approximately 60% of children will demonstrate some form of improvement at the end of the intervention. And it's because of results which have consistently come out from these studies that cognitive behavior therapy has now been recommended as the first-line intervention in terms of psychological intervention for the treatment of depression in many countries, and many guidelines have specified this. Well, what is cognitive behavior therapy? Well, very simply, and I'm just trying to provide a very brief overview for those of you who may not be familiar with CBT. It's based on the assumption that events happen and that somehow we will make some cognitive appraisal about those events, and that cognitive appraisal will affect our emotions and will affect also what we do. And we're particularly interested in the meaning and the interpretation that we make about the events that happen. Because we find, as has already been highlighted, that when people become depressed, they start to experience or sort of display dysfunctional cognitive processes and dysfunctional content in there. So that the information processing tends to be selective and biased. The individual starts to selectively attend to negative information, to information that confirms themselves as a failure, their experience as somebody who cannot be successful, and the future as hopeless, and they are helpless to influence it. And in turn, those sorts of cognitions will result in a significant impact upon emotions. So emotions go down, low mood is very common, and you have a variety of the physiological symptoms which are associated with depression. And when you think like this and you feel like this, the effect upon what you do means that people become deactivated. They become socially withdrawn, they lack motivation, they want to stay at home, they don't want to go out, they find it difficult to engage in many of the typical aspects of everyday life. So as we were saying earlier, when they have these symptoms of low mood, instead of getting out and getting busy, the reverse happens, people withdraw, and when people are spending considerable time on their own, not doing very much, then they ruminate. They rehearse what's been happening, these cognitions become stronger, and the process becomes a self-reinforcing process. Well, are there deficits in cognitive processing? Do we have research which have actually highlighted that there are deficits in processing in children? And the answer to that is yes, and we've already heard from Professor Kovacs about some of the research which has looked at this. But there are a number of studies, lab-based and also those comparing clinical and non-clinical groups, that have found that young people, when they are depressed, tend to attribute anything that positive happens much more likely to external events. So it's not about them and their skills and what they can do. It's because external events have happened and they might be lucky or it's down to somebody else. They tend to have more negative perceptions of themselves and expectations about their performance, that they won't be successful. They have the bias where they are constantly selecting and trying to attend to the negative events that happen. And they tend to have the effect of generalizing failure from one aspect of their life to other aspects of their life, so the thing becomes an overwhelming sense of hopelessness and helplessness. So we have some evidence that there is quite a lot of deficient processing that takes place when depression kicks in. And what happens when people undertake cognitive behavior therapy is a number of steps. But one of the key things people are helped is to try to identify and understand more about the way they are thinking, appraising, and the meaning which they are ascribing to the events that happen. If we're trying to understand that, it begins to elicit some of the biases which might be there, the selective attention, and then young people are helped to reason with this and to try to develop some alternative explanations about the events which are happening in order to arrive at a bit more of a balanced way of appraising events, which in turn has a beneficial effect upon their mood. There tends to be an element which is designed to help the young person understand their emotions, better understand the physiological symptoms and why they happen, but also, most importantly, to actually help them to develop strategies for dealing with their emotions in other ways which are more helpful, rather than withdrawing and isolating themselves and precipitating their symptoms. And there's interventions which are designed to change their behavior. So again, Professor Kovacs mentioned the idea of behavioral activation, trying to get people who are stopping their lives to become more busy, to become more activated, to re-engage in some of the pleasurable things which have taken place. Self-reward is very common, and then teaching a set of skills in terms of problem solving, dealing with everyday peer relationships, which often become major triggers for some of these young people hooking into depressive symptoms. And in CBT, this occurs within a context which people often describe as this sort of collaborative empiricism, whereby people are encouraged to work together to check out, to find out more about some of their assumptions, the meanings which they're ascribing to events, so that they're becoming scientific investigators who are sort of attempting to check out systematically the evidence for and against their different ways of thinking. And this often happens through a sort of Socratic process where the young person is helped to question and to reflect and to consider alternative ways of construing events. And another very powerful technique is that of guided discovery, where you set up experiments just to test out whether in fact your assumption or your prediction will come true, and through that you start to develop some alternative ways of appraising events. Now, typically, if you're going to be doing CBT programs with children, it tends to go through a number of sort of sequential steps, Obviously, this needs to be based around the needs of the child, but I thought I'd just outline for you some of the key focus which happen as people go through CBT programs. And at the very beginning of any CBT program, when you're working with clinical children who are referred to child mental health services, is this motivational engagement stage. Very, very important, because when you're working with people who are depressed, they feel hopeless, helpless, and that their efforts aren't going to be able to produce very much change. So there is a key aspect of any psychotherapy, which is about engaging young people, trying to motivate them, trying to work out what their goals might be, and to provide some basic psychoeducation in a CBT cycle about how their thoughts, feelings, and current behavioural styles actually relate together and provide a good way for thinking and testing out what happens. If you don't do that, then people won't be able to move to the next stages, which are about the active change. So the idea of engagement, motivational enhancement early on is fundamental to a lot of the work with depression. Typically, interventions would then focus onto the behavioural domain. And one of the things which people would do here quite quickly is to look at this issue of behavioural activation. Can we get people busier, re-engaging with some of the activities which they used to enjoy so that they can start to do the things that made them feel better? Then there's often an element which would follow, which would look at understanding much more the emotional side of their response. This is about emotional recognition and then thinking about alternative ways of doing something to make yourself feel better. So when you do feel rotten, rather than just live with it, what can you do to start to make yourself feel better? What sort of skills, techniques can we help you to develop? Then the interventions typically then at this stage would have more of a cognitive focus, and it would be at this stage that we would introduce the ideas of helping young people to identify the way they might selectively or biasly attend to certain information, to look at some of those errors, the thinking traps which they might fall into. And through developing that awareness, you can then start to help young people to question, to test out, and to challenge, to see whether in fact they are seeing the whole picture, whether there's some alternatives which there might be possibilities to consider, so that you start to broaden out their understanding to different possibilities with a view to developing a more balanced way of thinking. And then they tend to put all those skills together to think about problem solving, developing better communication and social skills, so that we have a chance to then develop the young person's interactions with their peers so that they are more successful and then can build on the positive ideas which they're now beginning to develop about themselves. And most importantly, relapse prevention. We've heard about this previously. Relapse is common. So how can we try to make sure that young people can plan for the future, can expect the possibility that relapse might occur, to see that, to be able to predict it, and to think about the skills for key learning which they will be able to use as soon as they notice that is happening. So, what about the early studies then? So, CBT, as I told you earlier, seems to have quite a good evidence base, but the early studies suffered from a number of methodological problems. The early studies were largely efficacy studies. They were basically trying to demonstrate that cognitive behaviour therapy produced positive effects, which is good. It's a good place to start. But what you find is that a lot of these studies involved comparing CBT to waiting list groups, and they were often delivered in research centres, research clinics, which were very different to everyday practice. You find very large effect sizes in some of these early studies. But when you actually consider their applicability to everyday practice, and when you start to look at the more severe groups, you find that the effect sizes start to reduce. Because in some of the earlier studies, they had very mixed categories of children. So they had children with low symptoms, we had children with clinical diagnosis of depression, and when you actually look at the effect sizes for the more severe group who we would be meeting in our everyday clinical practice, they're much more modest, but nonetheless significant, but much more modest. We've also heard the importance about follow-up. Relapse is very, very common. In a lot of the early studies, follow-up time was very, very limited. So we have very little understanding about the maintenance, the sustainability of those effects into the future. So you can get a short-term gain, but does it last, given the knowledge that relapse is going to be very common? Then we have differences between the interventions. People talk about cognitive behavior therapy, but it often means different things. And very simply, the range of the interventions in some of these earlier studies range from a very brief 5 to 8 session interventions to 16. And what we now know is that there's more evidence that the 12 to 16 session interventions are much more effective than the short ones. So although I showed you the sort of standard treatment components of CBT programs, the emphasis, the way they're actually used within individual programs varies considerably. And so we're still left really with quite a problem about what's the active ingredients in CBT programs. Is it doing the cognitive work? Is it the behavioural activation? What is it that is making the difference? And age range. Few of these studies included any children whatsoever under the age of 11. So when we're talking about CBT for depression, I think that we're talking about CBT for adolescents with depression, not younger children. But there has been some recent research which has started to take our knowledge further forward. And there have been 3 studies in particular, I'm just going to briefly outline for you, which perhaps start to give us more indications about where we need to go and what ideas we can summarize about CBT in clinical practice. The first is the TAD study, which was undertaken in America, and John March was the key investigator on that particular project. And basically, they took adolescents with mild to severe depression and they randomized them to either medication, fluoxetine, CBT, or mixed fluoxetine and CBT, and some had a placebo pill for the first 12 weeks. And if you look at the outcomes at 12 weeks, CBT did not do particularly well. Compared to the placebo group, where 35% response rate, CBT achieved 43% at 12 weeks, combined to the sort of combination and the medication arms. When we looked at that at 36 weeks, CBT made a huge change. It then joined the other areas. But the problem which we have here is that there was the risk, and this was sort of highlighted by Professor Kovacs earlier, that some of the medications might get a faster response, but there is a risk. And the risk here was about increased rates of suicidal ideation. So what does it tell us? Well, it tells us really that the largest and the quickest response actually was obtained in the combined medication and CBT group. CBT got there, but it took some time. And again, that's not surprising because CBT is about learning a set of skills which will take time to learn and to be able to implement. But we don't know what happened in the CBT program, but it was an interesting observation from John Wise when they did their meta-review in 2006, who noted that of the 23 CBT programs they looked at, 20 of those programs achieved significantly higher effects for CBT than they did in the TADS group. So I don't know what they did in the program, but it was interesting that the CBT in that group seems to be less effective than in the other trials. Then we had the ADAPT study, which was undertaken in the UK by Ian Goodyear, And this was a group of more severely disturbed adolescents with moderate to severe depression. And interestingly, what they did was that they provided these with a very brief intervention to start with. And this group of young people failed to respond to that and were then allocated to either medication and routine care, or medication, routine care, and 12 sessions of CBT. The 28-week follow-up, CBT group didn't do as well as the group who just had medication and routine care. So the authors concluded that CBT didn't seem to have any additional effect over medication at all at 28 weeks. But again, it sort of raises more questions, because given the rate of change which we found in the TAD study, where you might notice that at 12 weeks CBT wasn't so effective, but by 36 there had been a significant increase. Whether these gains would have continued past 28 weeks, we just don't know. But nonetheless, it does not provide strong support from this study that CBT on its own or being added to medication is actually adding anything to the medication at all at that stage. And finally, just the Tortilla study. And this again is a very interesting study which looks at resistant depression. So these are adolescents who had already been started on an SSRI who had failed to respond, and they were then allocated to a different SSRI plus or minus CBT, or they were switched over to venlafaxine plus or minus CBT. What they found in this study, though, with the group of young people who failed to respond to an SSRI, was that CBT being added to the medication actually produced a very more significant response rate. So let's just put this together in terms of the conclusion about what these new studies tell us, and then to think about what we need to consider for the future. Well, I think the data is quite clear that there are many randomized trials now, and CBT is by far the best evaluated psychological treatment for adolescent depression. It seems to be effective for about 50 to 60% of adolescents with mild to moderate depression. It does help those with severe depression, but significant improvements can also be obtained by medication. And the addition of CBT to those children who have failed to respond to an initial trial of SSRI seems to be beneficial, at least in the short term. We don't know about the longer term gains. But my final thoughts are about the future and where we go next. So that's the past 20 years of research trials. And I'm sort of left really thinking, well, this is good enough. What are we going to be able to do to the 40% of young people who are failing to respond to those interventions at the present time? So it's very good, 60%, that's great, but there's 40% of young people who are not responding at the present time. What about young children? And Professor Kovacs made some interesting summary about some of the work which she's undertaking now, thinking about how we can make interventions more accessible for young children. But what about CBT-based interventions? Because CBT-based interventions are able to be delivered to children 7 years and upwards quite comfortably. They just need consideration about the way in which it is done, the way in which it's adapted, the involvement of parents, the emphasis between cognitive and behavioural work, but there's many ways in which the programs can be adapted to be more suitable. But what are the effective ingredients of CBT? What is it that really does make a difference? And the slide from Professor Kovacs showed about the idea of deconstruction studies and behavioural activation. Very, very important. Is working directly with children's cognitions a fundamental part of CBT that is important and is effective? What are the elements so that we can package them together in more focused, targeted interventions which should hopefully increase the effectiveness? And I suppose I just want to end with this slide, this final comment, which is that in clinical practice, We need to get better at identifying treatment mediators and treatment moderators. And for CBT, like any other intervention, we need to become more focused in terms of understanding which sort of treatment packages, treatment components, delivered in what sort of way, to which children with what level of severity are effective in reducing what symptoms, both in the short term and the long term. And I'm going to leave you with that thought and finish there. Thank you.